Yes, Dr. Sachin, we can start.
Wait, just wait for.
Yes. Continue, ma'am.
I mean, should I start with the lecture? Or we should wait for some more participants to join?
No, ma'am. You start. People will coming. We will add on.
Okay. Okay. Thank you very much, Dr. Sachin and ISA NANDED for giving me this opportunity. And greetings from Mumbai. May I request others to please mute? Thank you. So, WHO has announced obesity as a global health problem and with ever rising prevalence. Percentage of morbidly obese women has doubled in the recent past, and in the last decade, it has increased enormously. And hence, the number of obese parturients coming for anesthesia are also on the rise. Obesity and pregnancy is a challenging task to manage due, due to compounding effects. May I request others to mute, please? There is a lot of disturbance. Thank you. Due to compounded effects of pregnancy and obesity, these patients are at very high risk of perioperative complications. And a recent report in the Maternal and Child Health Inquiry Committee, which was published in BJA, has mentioned obesity as a major risk factor for maternal morbidity and mortality, and also neonatal morbidity. WHO systemic analysis of closed claim suits has pointed obesity as a major cause of perioperative complications and also anesthesia and airway related maternal mortality. Hence, the objective of today's talk is to cover this topic in detail with related to anesthesia concern and management for elective as well as emergency LSCS. So our patient, which we recently did few months back, was a 33-year-old primigravida with precious pregnancy, weighing 124 kg with a BMI of 34. Known case of gestational diabetes mellitus, pregnancy-induced hypertension, and obstructive sleep apnea. On the day she was admitted as emergency and diagnosed COVID positive, she was posted for emergency LSCS. She had and it was due to fetal distress and large baby. On quick examination, she was a case of difficult airway with short neck, heavy pad of fat around the neck, heavy shoulders and breast, MPC3, a large tongue. Vitals were within acceptable range with a BP of 160 by 90 on labetalol, heart rate of 92. However, air entry was decreased on bilateral basis, and oxygen saturation on room air was 90%. And whatever emergency investigations were available, they were within normal limits, but blood sugar was very high. This was the patient. So we took very high risk consent in view of perioperative ICU.
Madam, sorry to interrupt you. Your
Yes.
slides are freezed, I think.
Freezed?
Yes, only one slide is on the screen. Other slides are not.
Okay.
We're not able to see other slides.
Okay. Just a sec. Cool.
Yes, ma'am.
Slides are freezed, they are saying. No, start sharing, yeah. Now, are my slides visible?
Yes, ma'am. Yes, ma'am.
Now, are they moving? Are
Yes,
they changing?
Yes.
Okay,
Ma'am. Go ahead.
okay. Thank you. Sorry for the glitches. Yeah, so my patient was 124 kg with BMI of 34 and having saturation of 90% on room air. So we took very high risk consent in view of perioperative ICU care and ventilatory support, and keeping everything ready for difficult intubation and standard care for aspiration prophylaxis. We gave combined spinal epidural anesthesia with low dose intrathecal bupivacaine followed by graded epidural anesthesia. left uterine displacement was maintained using a wedge under the right buttock. And on assuming supine position, saturation was further dropping in spite of high flow oxygen. So we gave a ramp position after the level was fixed, and we started CPAP intraoperatively, which improved the saturation to 99%. This patient was done uneventfully. Total surgical duration was 2.5 hours, and CPAP was continued in the post-operative period. Pre-op, she did not have, of course, chest X-ray and CT scan, but however, post-operative CT scan showed Corat score of 8 to 10, but she required, due to her obesity and COVID, CPAP for a prolonged around 15 days. And even low molecular weight heparin needed to be started in view of query pulmonary embolism. She had a long recovery, however, discharged on 20th day with a, and she went home 20 kgs lighter. So exact definition of obesity in pregnancy is not very clear. However, pre-pregnant BMI of more than 30% or weight more than 90 kgs or 20% increase in weight during pregnancy can be considered as obese parturients. Various methods to measure obesity are ideal body weight, that is Broca's index, which is height minus 100 for adult males and 105 for adult females, or BMI Quetelet index, which is weight upon height square, or lean body mass, which is 100 minus fat percent upon 100 into body weight. WHO has classified obesity based on BMI for health risk stratification, and BMI above 30, in all the risk increases significantly. Various pathological changes of obesity, they already affect all the systems, and in addition, physiological changes of pregnancy, both these have compounded effects and may cause further decompensation in the patient. Cardiovascular system in particular faces major brunt, with specifically of our importance is highly exaggerated supine hypotension syndrome, which on assuming supine position, there can be sudden collapse of the patient, and there are case reports wherein authors have reported sudden cardiovascular collapse on assuming supine position. Then there are very high chances of uncontrolled preeclampsia in these patients. In addition, cardiovascular comorbidities like DM, hypertension, coronary artery diseases, arrhythmias, they are common. So whenever, if it is an elective case and time permits, detailed cardiovascular evaluation is warranted in these patients. These patients have potentially difficult airway. Chances of mask ventilation and intubation both are difficult due to short neck, pad of fat, mucosal edema, large breast, and difficulty in positioning. Also, pulmonary complications are increased due to decreased volumes and capacities, small airway closure, airway obstruction, VQ mismatch, and most importantly, obstructive sleep apnea, which is even exaggerated in assuming supine position. So all these points make these patients highly susceptible for early desaturation during apnea and high risk of perioperative pulmonary complications. Obese parturients have very high risk of preeclampsia, 10 times the normal parturients, and gestational diabetes. Also, obesity metabolic syndrome is common. Deep vein thrombosis and resultant pulmonary embolism are also commonly seen as a complication and are the causes of sudden maternal deaths in obese parturients. Anyways, obese patients are at high risk of aspiration, and these obese parturients have very high gastric volume and decreased pH, and also the Elias tone exaggeratedly decreased. Also, highly delayed gastric emptying time. All these factors make these patients highly susceptible for aspiration and Mendelssohn syndrome. In addition, if the patient is post gastrectomy or gastric bypass, which have post bariatric surgery, these patients are even at higher risk for aspiration, and the NBM status does not hold any value in these patients. So they have to be like amply prepared for aspiration prophylaxis, and enough care should be taken to prevent the Mendelssohn syndrome. Pharmacokinetics and dynamics is altered due to change in volume of distribution, lipid solubility. There is higher sensitivity to depressant effects of sedatives, and MAC is decreased. As the net effect is unpredictable, titrated doses should be used, and use of dosing scalar is recommended. That is total body weight, if you use for all the drugs, may lead to overdose, and ideal body weight may lead to subtherapeutic doses. So ideal body weight should be used only for benzodiazepines and neuromuscular blockers. Rest all other drugs can be given by using lean body weight. Uh, Already in pregnancy, neuraxial anesthetic doses are reduced due to variety of reasons. In addition, in obese parturients, there is decreased volume of CSF and increased kephalate spread of local anesthetics, as excess adipose tissue in the buttocks causes relative Trendelenburg position. However, you need not to reduce the doses even further. You may use the same dose, but learn to control the level in obese parturients, maybe by changing the thoracic posture or adding a pillow under the shoulder. Obese parturients are prone for variety of maternal and fetal complications. Numerous maternal consequences include increased risk of cesarean section, prolonged surgery, postpartum hemorrhage, and even mortality with related to infections, DVT, pulmonary embolism. And fetal complications include increased risk of congenital malformations, mainly neural tube defects, macrosomia, shoulder dystocia. They are prone for birth traumas, increased NICU admissions, and high risk of stillbirths and perinatal mortality. So, anesthesiologists should be involved as early as possible in care of obese parturients. For the detailed assessment, antenatal assessment, preferably early in the third trimester, so as to formulate detailed plan for labor analgesia, cesarean section, and postoperative care. Detailed comorbidity assessment and multidisciplinary involvement, mainly cardiology, endocrine, and pulmonologist, for evaluation, optimization, and perioperative planning is essential. Optimization of mainly blood pressure, obstructive sleep apnea, blood sugar is very essential for optimum postoperative care. And detailed communication and planning, risk stratification, and planning detailed perioperative plan is essential. Again, reevaluate these patients on admission for delivery, or if at all they again get admitted for emergency procedures. Again, detailed PSC including history, examination, and necessary investigation. Checking room air oxygen saturation and at rest oxygen saturation in supine position and sitting is very important. Accordingly, we may plan our further investigation if time permits, and at all if ABG in required, and whatever routine blood investigations, and in addition specialty investigations if it is an elective case. We need to establish a rapport with the patient and allay anxiety. Perioperative preparation and anticipation of various complications is essential. We have to ensure the ICU, HDU bed perioperatively, DVT prophylaxis, preoperatively, preferably mechanical stockings and pumps, and postoperatively, we may consider heparin. If the patient is having OSA, then incentive spirometry, or if at all required, CPAP needs to be started right in the preoperative period. Depending upon the weight of the patient, operating tables limits should be checked, and their side support table extended should be checked. Availability of adequate size NIBP cuff, difficult airway card, readiness for CVC and arterial cannulation if need arises, and different sizes of regional anesthesia kit with extra long spinal needle should be made available always in the obstetric OT. These patients always have compounded risk and limited physiological reserve. And the difficulty starts right from the vascular access, positioning, airway, regional techniques, and supine hypotension syndrome, which is highly exaggerated as large panniculus adds to the compression of the vessels, decreased reserve and airway obstruction, and of course increased incidence of postoperative complications. And hence elective labor analgesia is highly recommended in these patients due to variety of reasons, as it decreases oxygen consumption, strain on the heart, and also as there are high chances of instrumental vaginal delivery or cesarean section, labor epidural, if it is already there, can be augmented for these purposes. So ambulatory labor analgesia with plain epidural should be ideally started early in the labor. No need to wait till the dilatation. Or if at all starting later, then combined spinal epidural is a technique of choice, which is more versatile to titrate. Now, central neuraxial anesthesia is the recommended technique for anesthesia for cesarean section in all obese parturients, unless there is any absolute contraindication for spinal anesthesia or per se central neuraxial anesthesia. And among central neuraxial anesthesia, the preferred technique in obese parturients who weigh more than 120 kg is combined spinal epidural. And if not, then the next comes, of course, preferred technique as spinal. GA would be indicated only in patients where there is absolute contraindication of spinal due to coagulopathy or any other reason, or there is failure of central neuraxial block. So whatever technique is of anesthesia is chosen, standard care for cesarean section is highly emphasized, which includes aggressive anti-aspiration prophylaxis, reducing pH with sodium citrate, as these patients are highly prone for microaspirations, preventing supine hypotension with left uterine displacement, preferably by wedge under the buttock, as table tilt is difficult. Patient must be firmly secured to the operating table. Pressure area should be adequately padded. Oxygen supplementation throughout patient transport, induction, every time it is must. And additional experienced help should be sought for right from beginning of the case. Preparedness for anticipated and unanticipated complications is crucial. Spinal anesthesia is still the technique of choice in certain selected cases of obese parturients, like maybe up to 100 kgs or 110 kgs, wherein the surgeons are confident that they would not be taking a long duration. Usually surgical duration is prolonged. For average duration they have documented is more than 2.5 hours. So if at all surgeon is confident and there are no associated complications, we may go ahead for single shot spinal anesthesia, which is of course fast, reliable, and gives dense blockade and excellent operative conditions. However, it is technically difficult, and if the surgery duration prolongs, then what next? That you may have to give GA or the other sedation, and which again risks the airway. So, and exaggerated spread is documented due to the curvature of the spine. However, dose you may continue to give same as we give in normal parturients, maybe 10 to 12 milligram of bupivacaine should be okay. Only the level needs to be controlled. As little level goes higher up, already compromised respiratory system gets more compromised, and we may have to intervene the airway. And hence we recommend a technique of combined spinal epidural analgesia, and also has been recommended by multiple studies who have done meta-analysis on obese parturient patients. As these patients are prone for prolonged surgery, even in emergency situations, you may consider CSE, as the average duration to total performance of CSE is not more than 2 minutes with experienced hands. So even in emergency situations for sections, we can go ahead with CSE. It gives a faster onset of dense block, and then graded titrated level of the block can be used for extended levels. Preferred technique is needle through needle technique, as the needle stabilizes very well, and the success rate is more with needle through needle technique rather than using two puncture technique. However, in obese parturients, there are high chances of accidental dural puncture. Maybe even during labor analgesia, if you are planning plain epidural, or during CSE, there are high chances of accidental or unintentional dural puncture. And in that case, you may consider converting it to continuous spinal anesthesia by putting the catheter through the dural hole. You may thread the catheter 2 to 3 centimeter into the subarachnoid space, and it gives a good control of level, and give very low titrated doses. At the same time, high asepsis needs to be maintained because the catheter is in the subarachnoid space. And various studies have mentioned that even though accidental dural puncture is common in obese, the risk of PDPH is not so common. as obesity has protective effect against the PDPH due to elevated intra-abdominal pressure as it reduces CSF leak, and there is decreased pressure gradient between epidural and subarachnoid space, and hence ultimate CSF leak is reduced. Also, if you put a spinal catheter, then the healing or sealing around the catheter is better and it reduces the CSF leak. So various challenges which we may encounter during spinal or CAC is obviously the technical difficulties, difficulty to palpate the midline and spine. And that's why adequate staffing, lot of servants and staff should be there to hold the patient in a correct position and support the patient. And sitting position is recommended compared to lateral position, because sitting facilitates identification of the midline. Distance from skin to epidural space is less in sitting, and patient can guide midline. We may use taping like this to separate the fat from the midline. Or if available USG in the OT, then and if time permits, we may use USG guidance to identify the midline level optimal space and to calculate the depth of skin to epidural depth. It should be done pre-puncture, and the approach preferred is paramedian sagittal oblique plane. However, it has a doubtful value in emergency LSCS. We may consider using extra long spinal needles. However, do not get panic if you do not have these long needles, as 90% of the obese parturients normal length is sufficient. Only super obese morbids like weight more than 180 kgs may require extra long needle. Also, the CAC set which we use, needle through needle, that has the longer needle than your spinal, and that's why if you are using CAC, there are high likely chances that you may not require the extra long needles. Also, normal standard length needles are easier to manipulate and they provide better control. Hence, it is recommended to start with a standard needle, and only if required, you may switch over to longer needles. Now, general anesthesia may be indicated when there is absolute contraindication for spinal or it has failed. So, difficult airway preparedness is extremely essential in general anesthesia, as the incidence of difficult intubation is reported incidence is 33%, but it is even more. And difficult mask ventilation is always there, and you may have a rapid fatigue in your fingers, and that's why experienced and additional hands should be always present right before the induction. So never hesitate to ask for additional help for such patients. And all the gadgets required for ventilation and intubation, and always preferably use the ramp position like this we have used in this patient, with specialized pillows or even folded towels and all, so as to align the laryngeal axis and this external auditory meatus with the sternal notch, so as to have a clear view and easy intubation. Various difficult airway management cards everybody is well versed with. Just to quickly go through all assorted sizes of mask, airways, laryngoscopes, mainly stubby handle, video laryngoscopes, endotracheal tubes of assorted sizes, guides, bougie, frua. Most important is laryngeal mask airway, and preferably either ILMA or Prosil or any other with a gastric drainage tube should be absolutely handy, because these are the life saving in obese parturients. Other equipments include flexible fiber optic, retrograde, emergency surgical access like cricothyrotomy said. Also, Thrive, HFNC. These are the techniques which have been recommended by various guidelines also, as these patients have high chances of desaturation during apnea. So any intubation attempt or failure to intubate, there should always be high flow oxygen going. You may use a nasal cannula with 15 liters. However, the IDA has recommended using this Thrive, which may give up to 70 to 80 liters of oxygen flow. In addition, it provides a certain amount of CPAP, inherent CPAP, which helps to maintain the airway patent and reduces the obstruction. So standard general anesthesia, of course, optimum pre-oxygenation to achieve end-tidal oxygen of 90% is must. And you may use an open lung technique, that is adding CPAP or PEEP right from the masked ventilation stage. And standard rapid sequence induction intubation using propofol's choline is of choice, and cuffed endotracheal technique. Of course, no DSAT technique, that is with supplemental oxygen, nasal cannula or thrive. I have stressed this enough. And if at all your first attempt at intubation fails, second attempt may be tried by the most experienced person in the OT using all best techniques available, or you may directly go in for a Proceal LMA, which has been very successfully recommended to be used as a rescue technique. So these are the IDA guidelines for anticipated or unanticipated difficult intubation in obstetrics, and they have also recommended using second generation supraglottic airway devices, that is Proceal iGel, for difficult intubation in obstetrics, especially OBs. And if at all the it continues to be difficult, continue no desaturation with high flow oxygen supplementation. Intraoperatively, saturation may still be on the borderline, and you may improve by increasing FiO2, adding PEEP, optimum PEEP, or even if this does not help, you may elevate the fat, that is PANUS, manually and lift it above the chest, so it improves the oxygen saturation. At the time of extubation, always again watch for aspiration, hypoventilation, airway obstruction, and extubate only when patient is absolutely awake in semi-sitting position. Optimum postoperative analgesia with multimodal technique is recommended. If already epidural is in place, you may continue with that, and in addition add PCM NSAIDs. Opioids usually we avoid, as in obese they cause excessive respiratory depression. Ramifentanil is recommended in them, however we do not have it. LA wound infiltration and tab block. Tab block is actually difficult due to the planes identification. We may tell the surgeon only to infiltrate from inside into the plane, or if at all USG available, we may try with a long spinal needle. We can give the tab block. Postoperative complications, and mainly pulmonary, are very common. They are hypoxemia, atelectasis, pneumonia, myocardial infarction, deep vein thrombosis and resultant pulmonary embolism, infections, and even sudden maternal death. So early detection and prevention and immediate management of these complications is essential to prevent the mortality. So, close monitoring in the ICU, in semi-recumbent position, adequate analgesia, aggressive physiotherapy and incentive spirometry, CPAP if required, thromboprophylaxis, mechanical or the pharmacological using low molecular weight heparin, early ambulation, strict glycemic control. These are essential points we need to remember in the postoperative care. So, morbidly obese parturients, they have compounded risk and pose significant challenges to anesthesia management. Additional experienced help and multidisciplinary approach is essential. Early anesthesia assessment, optimization, formulating a plan. Preferred is labor analgesia, elective labor analgesia, and prophylactic epidural catheter. CSA is the plan of choice for cesarean section. Have always backup alternative plan ready, and backup your also. Preparation for difficult intubation and appropriate post-op care is essential for optimal outcome. These are few references. Thank you very much. Any questions?
In a nice talk.
Thank you, Dr. Sachin. Yeah. I'm sorry for the video. My video is not switching on in Google Meet.
Okay.
Do we have any questions?
1 minute. I will see in my clinics.
Hello, excuse me.
Yes.
Can you specify a little more about the 2D echocardiography for such patients coming for seizure, obese?
Yes. These patients usually have associated comorbid conditions, usually the morbid obese who have BMI more than 35 or maybe more than 120 kgs weight. In these patients, or even lesser kgs, but having associated symptoms of concomitant hypertension or any other symptoms due to the cardiac comorbidity, we may go ahead. It is not necessary in each and every patient. And if the patient is following up regularly in ANC, then might as well get a 2D echo done for all the obese patients.
Okay, fine. Yes, thank you.
विषय घेतला त्यामुळे तुम्ही आम्हाला मदत कराल आणि केली नाही.
सर कदम सर तुमचं म्यूट करा तुमचा. एनी क्वेश्चन तुम्हाला रेज करायचं तर विचारा.
Hello.
Yes.
Two questions. First is you are saying while giving spinal anesthesia, the dose what we are giving is the same as routine.
Yes. Routine means routine in pregnancy. Routine for
Yeah.
ANESTHSIA.
Routine,
Yes.
routine
Yes.
for ANESTHSIA. Obviously,
Yes.
routine for
Yes.
ANESTHSIA.
Yes. Yes.
How many times have you seen higher levels in that dose?
Sir, level specifically, I have not seen, but it is documented that the levels go higher in obese patients, even with the same like 2 cc or 2.2 cc. Also, you're using bupivacaine in pregnant patients, but if the patient is obese, with that also level may go higher up. But if you reduce the dose, then again there are chances of early receding, and these patients have usually prolonged surgery. So rather than reducing the dose, what they have recommended is you learn to control the level by adding pillows or changing the curvature of the spine. So what we do usually is we give the same dose but add a pillow under the shoulder so that you have a dense block where you are required and the level may not go higher up.
Okay, and second one is how many times or how much is the chance there are chances of post-op myocardial infection you have mentioned?
Yes, they have mentioned around 4 times more common than normal parturients. It is less common as compared to diabetes mellitus and PIH. These two are more common, 10 times more common. Chances of MI is 4 times more common than the normal parturient. So close monitoring is essential. Peri-delivery period is high risk. That time only a lot of changes occurring. So if that time is carefully monitored, should not be a problem.
Okay, thank you.
This 4 times more incidences of myocardial infarction, it may be in previously symptomatic patient also?
Yes, maybe, sir. Maybe those patients who are following up regularly ENC may have been picked up earlier, but many of the patient here, they come directly from periphery or something. In them, it is picked up, either just at the time of investigating before section or maybe even post-op.
Yeah, that's what my point was, madam. When previously I asked you the question regarding the 2D echo. During ANC, we actually request our gynecologist to get 2D echo done. Emergency may, then it may not be possible to send to cardiac. So many cases that like few of our cases we have witnessed myocarditis or then the blood pressures, then really clueless and situation.
Yes, 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 sir. These are the reasons they have very bad perioperative outcome. And that is why the recommended techniques are in many meta-analysis also they are mentioned as CSE, because then sudden hypotension, and if at all there is any component of MI or anything, it is not getting exaggerated. There is no myocardial strain because you are giving very low dose and then graded epidural. So that is why CSE technique, so as minimal strain on the myocardium. Same as if elective labor analgesia is planned, there is minimum strain on the heart and the resultant complications of MI and other things are reduced.
Okay, okay, fine, fine. Thank you.
Minal, madam,
Yes, yes.
I heard your Nagpur presentation on YouTube also.
Okay.
There one question from Yogan Bhatt sir that related to that you are repeatedly said thing that you don't need extra large spinal needle in this case.
Yes, yes, yes.
Just highlight on that topic.
Yes. Usually we always keep an obstetric OT and our general surgery OT one extra large, needle in case if required. But frankly speaking, we have done patients up to 150 kg and we have not used it till now. We have kept it as a standby if required. And it has been mentioned in many of the studies also that usually patients more than 180 kgs, they require extra long needles. And even if you think that you might require, you may still go ahead with a CSE set which has a little longer spinal needle than your regular one, and we are used to these standard length needles, so we find it very better control over the needle and easier to manipulate these needle in cases of difficult central neuraxial blockade. And hence all the studies recommend starting with the normal size. If at all you're not able to reach, or you think that you're just reaching, you may use the longer. Or one more technique Dr. Bhatt's advice that time is,
Yes.
if at all you do not have only long needles, you may make a small skin nick at the entry point, so you can advance your needle just a few millimeters more and you may reach the space. So making a small skin incision at the site of entry point can be taken care if at all you do not have a needle and you think you are in need of one.
Yes, in our setups like NANDED, in but sir really explained very well that
Yes.
in the midnight we got a call for cesarean
Mhm.
section and patient was obese. That time nobody
Ye-
was going to help you. So
Yes, yes,
really explained nicely, sir.
yes, yes, definitely.
Good evening, madam. Dr. Jayant here.
Yes, Jayant.
Madam, can you please elaborate about that USG guided neuraxial blockade in detail about these patients, specifically this patient, how to proceed with that?
Actually, it is only if you have USG ready in the OT and it is not super emergency, you may go ahead with USG guided. Otherwise, if you're going to procure USG from some other OT and try, then it is going to be very time consuming. So, in cases of elective obese parturient, definitely you should in fact start with USG guided. Secondly, you should be at least little well versed and used USG in other spines, normal spines at least before, because if you are first or in the beginning with the obese parturients, it might be difficult to actually identify the level and calculate the distance. So that is why initial little hands-on and a learning curve, you should have it in normal patients scanning the spines. So if you are well versed with that, then it doesn't take a long time. Actually, you may just usually we scan the spine in both transverse as well as the longitudinal sections. Okay. Here in obese parturients, the various studies, and we have also observed that rather than keeping the probe directly on the spine, you keep it paramedian or parasagittal, slightly tilted, and then the view is better because immediately next to spine you have a good window, and from there calculation of the skin to epidural depth is also easy, and you may identify the optimum level, which is the best level amongst those 2-3 spines which you are visualizing.
Okay, okay. But all these cases, we proceed by paramedian approach only, madam. Na?
Yeah,
Without,
it is. Yeah, and pre-puncture scanning always helps. Means pre-puncture, you scan, you mark, and
okay,
then only puncture under vision.
okay, okay,
Yes.
okay, ma'am. Okay, thank you, ma'am. Thank you.
Yeah. Thank you, Chen.
I think Naresh Paliwal sir was left. I think in this case, madam, related to you use bupivacaine heavy.
Hmm.
I think so.
Hmm.
Related to isobaric drugs, any experience on
Yeah.
obese patients?
I personally do not have, but there are, incidental reports of using combination of iso and hyperbaric for these obese parturients, because of course we do not want very high level and the resultant hypotension and complications. So there they have people have used a two drug technique where they have given the spinal at a higher level and initially injecting hyperbaric drug, a low dose, so as to cover the sacral and lumbar segment, and followed by that injecting another low dose of hypobaric isobaric drug, so which will give you adequate level above. So that technique, but personally I do not have experience in this because I have not used, so I may not recommend.
Any questions from audience? Other than investigation, you in this COVID era, other
Hmm.
investigations, what you like to comment on that?
Or see, that is what elective case patient coming from ANC period, evaluate every system, every, especially cardiovascular, pulmonary, because if at all possible, a pulmonary chest med evaluation, and if required further investigations with regard to OSA. Endocrine, very important because all the patients have uncontrolled sugars and cardiac. So these three specialty investigations, and other than that regular blood investigations and coagulation profile. If at all oxygen levels are low right from the beginning, we may get a clear picture from doing a arterial blood gases. That is all. And if uncontrolled PIH, then of course related investigations, platelet count, if at all low, then we may go for further coag profile like thromboelastography or something like that. But that will be specific to the particular complication or condition they have associated with this.
Thank you, madam.
Okay. So I guess, yeah,
Yeah,
looks we are done with the.
yes, yes,
Okay,
yes.
yes.
Almost one Paliwal sir's question, but he left for Caesar. Uh,
Okay, okay.
okay, he is from Amravati, Naresh
Yes, I
Paliwal.
think, yes, Dr. Naresh himself must have
Yes, yes,
used this to two drug technique.
yes, yes,
Yes,
yes.
yes.
So I want to talk on that, but sir left for Caesar. I just call in.
Okay.
Otherwise, any questions from audience? On the behalf of ISA NANDED and as a secretary of ISA NANDED City Branch, I really grateful for you coming on our platform, and I hope in future also you will come regularly on this platform for teaching us, and these remote places we need a lot of things from you to learn and do cases nicely.
Thank you. Thank you very much, Dr. Sachin and ISA Nanded. And all the best to everyone. Thank you.
So I conclude this. Thank you, madam.
Thank you.